He's pale, sweaty, he's clutching his chest and in a lot of pain. But the ECG is not showing any ST elevation, so is that okay? Well, there is a subtle sign in the ECG that tells you that the worst hasn't happened yet. This is a sign that you cannot afford missing. Let's talk about this. So in the next hour, we're gonna talk about STEMI, and we're gonna try to focus on two things: the STEMI definition and if there are ways to anticipate the STEMI before it happens. So this is gonna be done via discussing real life cases. So when I teach, one of the problems I've had when I was a medical student and early in my career, I struggled retaining information because I struggled to link the medical science to the clinical practice. So when I teach now, I always teach using stories because I think this is the only way, first, to show you that medical knowledge can be applicable and how to apply them to real life. And second is to create emotions that are attached to the stories, because any medical knowledge that will be attached to an emotion, it will stick to your memory for life. So this is what we're going to try to do today. We're gonna do some online exercise, all anonymized, don't worry. So if you're gonna start by scanning this QR code, it should take you to the talk page on Slido, and then we'll be engaging with this throughout the talk. Okay, enough of introductions, and let's start by the STEMI definition. I cannot talk about anticipating STEMI before it happens without making sure that we know what STEMI is first. So we're gonna put it through a case. So you're about to meet now your first patient, who is a 58-year-old male patient presented to the emergency department with a cardiac sounding chest pain and sweating that's been there for the last 5 hours. So active pain and sweating for 5 hours now. The patient is vitally stable, and the ECG showed an ST elevation of 1 millimeter in V5 and V6. So 1 millimeter of ST elevation in V5 and V6, this is the only thing you can see in the ECG. Question to you now is, would you consider this a STEMI? Yes or no? And I want you to answer based upon the STEMI definition that you have in your head. Go ahead. Let's see what you guys think. Okay, fine. So 63% of you said yes, this case is a STEMI case, and 38% said no, this case is not a STEMI case. Great. We're going to move on now to the next question. So do you think that this patient would qualify for primary PCI activation in your local hospital? Let's see how the answers are going to be this time. Usually they should go together. If you say yes to the first question, it should be a yes to the second, but who knows? Look at that. So this means that some of you said yes to the first question, it is a STEMI, but you know what? I am not activating the cath lab, which is interesting, and it happens each time I teach this talk. So I guess the reason for the difference in answers is based upon the STEMI definition that you've used. So I think those of you who said no, this is not a STEMI, they said it based upon the definition that comes from the Advanced Life Support. So the latest edition that was published 2021 said that STEMI means ST elevation, that's in addition to the chest pain, of 2 millimeters in two adjacent chest leads, that's V1 to V6, and or ST elevation of 1 millimeter in two adjacent limb leads. So that's lead 1, 2, 3, AVR, AVL, AVF. And you said that your patient has got ST elevation of 1 millimeter in V5 and V6, which are chest leads, and this is less than 2, which means automatically that this patient does not fulfill the criteria for cath lab activation, does not fulfill the STEMI definition. I think that's the reason for those who said no, they said it because of this. Anyone else said no, not a STEMI for a different reason? You can either talk or you can put it in the chat. Oh dear, no signs of life. Fine. I'll assume that you've all said no based upon this, and let's move on to those who said yes. I think those who said yes, either they said it because they were clinically concerned about the patient, in addition to the fact that there is a bias here, you're expecting something bad to happen because this is a teaching session. But anyway, I think some of you followed the American College of Cardiology guidelines. The STEMI definition has changed in 2013 and it is still applicable till today. They said STEMI is defined by 1 millimeter or more of ST elevation in two contiguous leads anywhere in the ECG except V2 and V3. As long as there is no left bundle branch block and there is no left ventricular hypertrophy. So 1 millimeter is enough in lead 1, 2, 3, AVF, V1, V4, V5, V6. 1 millimeter is enough. How about V2 and V3? Well, it depends upon are you a boy or a girl and how old you are. So young boys less than 40, you're allowed up to 2.5 millimeters. Older boys, that is 2 millimeters or more. And in ladies, we all know it's completely inappropriate to ask about their age. So they've just taken it out of the equation. Any female, the V2, V3, it's 1.5 millimeter regardless the age. So this is the American definition that's been applicable since 2013. Any more definitions? Yeah, let's go to the European Society of Cardiology guidelines. In 2017, they published this definition. They said it's exactly the same as the American one. So what you need is at least, you need two contiguous leads, as you can see here. And it is 2 millimeters. Let me just get it there. So they just followed the STEMI definition that is the American gave. So 1 millimeter in any other leads, and V2 and V3, they said exactly the same as the American one. So boys over 40, younger than 40, that is 2.5 millimeters. Boys younger than 40, older than 40, that's 2. And ladies, it's 1.5 millimeters in V2, V3. Anywhere else, that is 1 millimeter only. Any more? Yeah. There is the fourth universal definition of myocardial infarction. So this is the latest one that was published in 2018. And it's a general expert consensus document that's published every few years with representatives from the cardiology land from almost all over the world. And their definition was this: 1 millimeter of ST elevation in all leads other than V2 and V3. V2 and V3 exactly as we said before. So how about in UK? So in UK, there are two big guidelines that we follow. So the first one is the NICE guidelines. And I don't know if you've tried to check the STEMI definition and the NICE guidelines before or not, but if you try, you will find a very interesting definition. They said STEMI is defined according to the local policy of where you work, which is not that helpful. But there is also the SIGN guidelines for STEMI definition. So SIGN guidelines from Scotland, latest one that was published was in April 2016 about acute coronary syndrome. And this was the definition. So they defined ACS basically as 1 millimeter in of ST elevation in 2 adjacent limb leads and 2 in 2 adjacent limb leads. So this was very interesting to see. This is probably the only guidelines worldwide that follows the ALS definition rather than anywhere else. And to be honest, they haven't updated this since 2016. I think when they update it, they will change it because it just goes against the rest of the world. So let's go back to our case. 58-year-old male patient presented to you with a cardiac sounding chest pain and sweating for the last 5 hours. The patient is vitally stable. The ECG showed an ST elevation of 1 millimeter in V5 and V6. Question to you guys now. Would this patient qualify for primary PCI activation in your hospital? Okay. Let's see. Oh, look at the change in practice. So that means to me that more of you now are considering this as STEMI. Brilliant. So 1 millimeter of ST elevation anywhere in the ECG except V2 and V3 is enough. Don't wait for the full-blown STEMI because I'm sure that you all know that time is myocardium. And lastly, it's very interesting to think about it that way. What you think is not a STEMI in UK is actually a STEMI in many other countries. This is at least how I see it, looking at the guidelines. Anyway, so that was the intro of the talk for today, and now we can move on to the proper part of it. Let's talk about seeing the STEMI coming from a distance, and let's see if there are ways that we can use to predict the STEMI before it happens. Are there any pre-STEMI signs? There are few. We're going to focus on only one of them today. So here's a real case that we're going to start with. 58-year-old male patient, self-presented to the emergency department of Poole Hospital with a cardiac sounding chest pain that was ongoing for 30 minutes. So just to give you some context to the story, Poole Hospital is a medium-sized hospital in the south coast of England. They do not have cardiology in place. So if they see a STEMI, they'll need to immediately transfer to the nearest PCI center, which is in Bournemouth, and this is about 15-20 minutes from Poole. If it is a non-emergency cardiology case, so no need for PCI or no need for a pacemaker insertion, they admit locally under the medical team. So if this is a non-STEMI, they will admit locally under the medical team in Poole and then arrange for the transfer to be done later if needed. So this is kind of the context of the environment that you're going to face when you see this patient. So 58-year-old cardiac sounding chest pain in a hospital with no PCI facility. Past medical history was just hypertension, nothing else. Vital signs on arrival, as you can see here, bit tachypnic and a bit hypertensive, nothing else. So an ECG was done because the patient didn't look great, and this was his ECG. So I'm going to allow you a few minutes to look at this. Not a few minutes, seconds should be enough. I want you to retrieve the STEMI definition in your head because I'm going to ask you, would you activate the cath lab now or not? That this ECG would fulfill the STEMI definition. But let's talk about what Grace and Ahmed is talking about. Let's analyze the ECG. If you look at the ECG, you will notice here that the bit that we are going to be concerned about, the bit that looks a bit odd in the ECG, is this part here in the chest leads. If you look there, you will notice that something is not quite right about the T waves and the ST segment in V3, in V4, in V5, and in V6. They look a bit odd. They don't look like normal looking, happy ST wave that you would expect to see. And this is something called the De Winter sign. So let's talk about the De Winter sign. It's a relatively new sign in the ECG lens. So first reported by Dr. Hein Wellens and Dr. Robert De Winter in 2008 in an article that was published in New England Journal of Medicine. And what they described was this. They basically said that you need to fulfill these criteria. ST depression, no elevation, upsloping ST segment, followed by a tall symmetrical T wave that is upright. And that needs to happen in the precordial lead, so V1 to V6. It's the type of T wave that when you look at, you will think, what's the potassium of this patient doing? Because that looks like hyperkalemia to me. And if you read their article that was published in 2008, they specifically said that they've checked the potassium level of every single patient they've recruited, and they made sure that it was normal before the recruitment. So these are similar to the hyperkalemia changes, but with a normal potassium in presence of chest pain. When you see this combination, think De Winter sign, think a possible STEMI. Because this is the value of the De Winter sign. They found that it is seen in about 2% of patients with acute proximal left anterior descending artery occlusion. So acute proximal LAD occlusion in about 2% of cases. Before this STEMI happens, you will see the De Winter sign. So it's a new indication for cath lab activation as a STEMI equivalent. So if you compare something like Wellens syndrome, for example, with the De Winter sign, Wellens syndrome is some sort of a subacute proximal LAD occlusion that you should treat urgently. While the De Winter sign, the patient will be having STEMI in front of your eyes, you must treat urgently. Emergently. Here's the paper that was published in New England Journal of Medicine in 2008 talking about a new sign in the ECG that points towards proximal LAD occlusion. And basically, they published this. It was a study. They've recruited over 1,500 patients, and they found this sign in about 2% of the cases. So that was in November 2008. Then a year after, in 2009, they've increased the number of patients they've recruited. They are still there in the writers of this paper, and basically this time they've recruited almost 1,900 patients, and the outcome was very similar. About 2% of cases had the De Winter sign before having the ST elevation. And since 2009, the evidence kept just growing that when you see the De Winter sign, it's highly predictive of acute LAD occlusion. And many authors kept proposing this as a STEMI equivalent sign, and they kept pushing towards including it in the guidelines as an indication for cath lab activation and thrombolysis. And the reason for that is because the ECG will not show any ST elevation. They are technically not fulfilling the current guidelines, and they were pushing to include that. Question is it included in any guidelines yet? Wasn't till just 2 years ago. So 2 years ago, in the American College of Cardiology published this expert consensus decision. And this was the first time ever for the De Winter to be mentioned clearly in a guideline. So this is a table from these guidelines, from this document, and they put the STEMI equivalents, and one of them is the De Winter sign. So now you've got something to refer to if you get any resistance from the cath lab team regarding cath lab activation. Well, the American College of Cardiology published this, and they think that the De Winter sign is STEMI equivalent. So to be treated like a STEMI. So let me give you some examples about the De Winter sign from the cases I've seen over the years. Here's an example from Winchester Hospital, from the hospital that I work in. This one was 29-year-old male patient with no risk factors for whatever, and presented with chest pain. This was the presenting ECG. I hope that you all agree that we've got a good-looking De Winter sign in V2, in V3, in V4, and in V5. This patient had posterior leads done with no ST elevation. Cath lab was activated based upon this ECG with the De Winter sign, and the patient was transferred from Winchester to Basingstoke, the primary PCI hospital, and was found to have a completely occluded LAD. So Ali's commenting about the age, and this is an important point. So when one of my junior colleagues come to me to discuss cases, and they the patient will be coming with chest pain, and I would say, have you ruled out ACS? And they say, the patient is so young for this. I think we should stop thinking about the age as a thing at all. So over the years, the age for having risk factors for ACS kept going down. And if you look at the rubbish that we eat every day, you would understand why. And basically, I've sent people to the cath lab in the early 20s. I've sent a 19-year-old to the cath lab. And by the way, a few months ago, we've had a patient who presented to our hospital who was, I think, 10 years old, came in with a stroke, secondary to vasculitis. Age means nothing. You will never know whether the child that is coming to you with chest pain has got Kawasaki disease as a child or not, and whether they're having a risk of having coronary occlusion or not. So get the age out of the equation when you assess for chest pain. Just assess the pain and let's see how it goes. So there is a question about the difference between urgent and emergent. So basically, it's kind of how quick do you want to do your intervention? So so quick means immediate. So that's the emergent, while urgent is kind of within 24 hours to act on. So yeah, so forget about the age. This patient has had, without any apparent ACS risk factors, a completely occluded LAD, and this was the presenting ECG. Here is another example that was sent to me by one of my friends in Dubai, a 45-year-old male patient with chest pain, and this one was smoker. And again, if you look at the ECG here, very apparent in V2 and V3 that we have got a De Winter sign here. Without even repeating this ECG, cath lab was activated, and this patient was found to have a completely occluded left anterior descending artery. Here's another example from UK. And again, if you look at V2, V3, it's very obvious that we have now here ST depression that is upsloping, followed by a tall symmetrical T wave. This is a De Winter sign. Activate the cath lab. Here's another example from Egypt. And again, ST depression, upsloping, followed by a tall symmetrical T wave in presence of chest pain. You're done. If the potassium is normal, this is a STEMI coming. So let's go back to our case. Let's say that you've seen this patient, you've never heard about the De Winter sign. I guess most of you, if they're not sure what's going on, but they've got a patient with chest pain and an ECG that is looking a bit odd, you will just repeat the ECG. I hope that you would do this. I think this is what I would do if I'm in your position. But the question is, what time frame would you allow for the changes to happen before you request the next ECG? So let's be realistic and let's be honest and answer the question. When you ask your nurse to repeat the ECG for you, how long do you give them? Do you say, repeat the ECG in 5 minutes or 10 minutes or 15, 20, 30, 60, whatever? So just pick the honest answer that you would do here. So scan the QR code and you should be able to answer via your phone QR. Okay, so 15 and 20 are the top, and then some with 5, some with 10, some with 30, and I'm really glad to see that, 60's got no one. Yeah, there is nothing that we would repeat in an hour in ED. Great, so 15 minutes so far is the winner here, followed by 20. Okay, that's interesting. So I've left here the timing on the ECG paper intentionally. So right now, this is the time, and this is ECG number 1 that is showing the De Winter sign. Let's get a repeat ECG. Number 2 was 9 minutes later. Can you spot the difference? So now we're looking at a bang door STEMI, 9 minutes from ECG number 1. Now we have an ST elevation in V2 and V3 and V4. So cath lab was activated. We were waiting for the ambulance to come and take the patient, and ECG number 3 was done 10 minutes later. And not much difference, still ongoing STEMI. 1 minute after ECG number 3, VF cardiac arrest, shock, 1 cycle of CPR, ROSC, GCS 15. Medical treatment was given and post-ROSC ECG was done, and this is the post-ROSC ECG. This ECG was done 4 minutes after ECG number 3, and it was done 23 minutes from ECG number 1. And this is the difference now. So, ECG number 1, De Winter sign. 9 minutes later, it looks like this. 23 minutes from ECG number 1, it looks like this. So if you're someone who's going to repeat the ECG in 10 minutes, sorry, you've just missed the STEMI. If you're someone who's going to repeat the ECG in 20 minutes, sorry, you've just missed a VF cardiac arrest. The patient was then transferred to Bournemouth Hospital for primary PCI and was found to have a completely occluded LAD. I've got no credit at all saving this patient's life. All the credit goes to Hazel, my colleague who's now a consultant in Poole Hospital, who saved his life. The only reason for me to get involved was because this patient presented again to Poole Hospital ED about a month later, and I was there that time. So His ECG was abnormal, so I thought I'm going to check for an old ECG. And I still remember the reflection of my face on the computer screen when I saw the winter sign. I was like, that's the winter. I hope they've done repeat ECGs. And I kept clicking next, watching this STEMI evolving, and my smile was just getting bigger and bigger. It was very cool. I mean, for me, not for the patient, of course. Anyway, and of course, I've admitted this patient. He just said, I've got chest pain now. I've had a STEMI and a cardiac arrest a month ago. Here we go. You've got yourself a hospital bed. Found to have nothing and was sent home the next morning. But it was a very good case to be aware of. So here's another example from Barnsley Hospital in UK. Barnsley is a hospital that is very similar to Poole in the fact that they do not have a cath lab there. And the ambulance crew, they know that. So if there is a patient that requires a cath lab activation, they will bypass Barnsley and go straight to the nearest PCI center. If they think that the case does not require PCI, they will go to Barnsley Hospital. So this is the ECG, the pre-hospital ECG of a patient who's got chest pain. So the ambulance crew saw this ECG and didn't think that there is anything there that indicates bypassing Barnsley to go to the nearest PCI center. So presented with this ECG to Barnsley Hospital, but in Barnsley, all what they did was they repeated the ECG. And here is ECG number 2. And the patient was then transferred to the PCI center. So this was an unnecessary delay, a waste of myocardium, just because of the not spotting the De Winter sign in a timely fashion. Here's another example of a 49-year-old male patient. The first ECG was this. And again, if you look at V3, V4, V5, we've got an SE depression upsloping followed by a tall symmetrical T wave. That's a De Winter sign. You don't really need too much here of thinking. But this ECG was rejected by the cath lab team. So patient stayed in ED for a second ECG, and this was ECG number 2. And this ECG was accepted by the cath lab team because now it is fulfilling the STEMI definition. But to be honest, I think we've wasted unnecessary myocardium here. So this was a waste of time and a waste of myocardium that shouldn't have happened. So be careful when you get the De Winter sign. It is a STEMI in the evolving stage. Don't waste any time with that. Okay, one more case from Tanta University Hospital in Egypt. 45-year-old male presented to the hospital with this ECG. This is the pre-hospital ECG and a beautiful looking De Winter sign in the anterior leads, V2, V3, V4, V5, maybe in V6 as well. That was ECG number 1. ECG number 2 was this. And now we've got a full-blown STEMI with what we call the shark fin STEMI in V2 and in V5. Very obvious there. ECG number 3 was this. So VF cardiac arrest, and unfortunately this patient didn't make it. So again, when you see the De Winter sign, be quick and be proactive. This is a very interesting one. This one is a 53-year-old male presented with chest pain. I'm going to show you a series of ECGs, and I would like you to think about it and ask yourself, will I activate the cath lab at this stage or not yet? So, ECG number 1. This patient is got chest pain and ECG number 1. Would you agree that there is an ST depression in V2 and V3 that is upsloping followed by a tall symmetrical T wave, i.e. this is a De Winter sign? I would say so. Would you activate the cath lab now? I think you should, but let's say that you've decided that the guidelines are still not strong enough, or you've never heard about the De Winter sign, so you decided that you're not going to activate the cath lab now because it's going to be rejected. There is no point. Great. Let's repeat the ECG. I want you to trust me on this. I've got the original ECGs with the timings written on them. I'm more than happy to share them with you if you do not trust me, but I know that you will. 4 minutes later, this is the ECG now. Will you activate the cath lab? So right now, we've got some ST elevation in V2 and V3. Some of you will say, yes, let's activate the cath lab, and some of you will say no. I think those who will say no will say, well, this patient is 53-year-old. You said in the definition that you need 2 millimeters of ST elevation for the over 40. These are not 2 millimeters in V2 and V3, so not yet. But those who will say yes will say, our starting point is actually in V2 and V3, a millimeter or two below the baseline. So when you move from this to be above the baseline by 1 millimeter, actually this is a 3 millimeters deviation up. So some of you might activate the cath lab on this one based upon this. But anyway, if you're not one of those, or if you slow a bit, let's just get another ECG. 1 minute later, 40 seconds later, 35 seconds later, 9 minutes later. Clearly, I've had more ECGs in the gap between the 35 seconds and the 9 minutes, but the screen was not big enough to put them all in here. This is how quick things can change. So here is what I personally do when I have a patient with chest pain and an ECG that is showing the winter sign. I take this patient to the resus room and I get the ECG machine and I attach it to the patient and I let the nurse in charge know that this ECG machine is mine now. Find another one for the rest of the department. I've got the sickest patient in the department now. And I keep pressing print while I'm on the phone to cardiology. This is the only way to get ECGs with a time difference of 35 seconds. So the STEMI is happening and I don't want to waste any time. So I do not stop printing while I'm on the phone to cardiology. Whether they'll accept it as a DeWinter or they'll accept it as a STEMI, it's going to happen anyway. So this is the only way to catch the DeWinter sign in a timely fashion. And I think this slide is strong and a powerful reminder for us regarding repeat ECG in 15 and 20 minutes. It doesn't work, not with DeWinter. And the final thing that I want to talk about here is the DeWinter sign. When it was reported by Robert DeWinter and Hein Wellens, it was reported in the anterior leads as a sign of an LAD occlusion. But in 2018, this case report came out with a DeWinter sign that was reported in the inferior leads, and it was found to be related to an RCA occlusion. So bottom line is, when you see the DeWinter sign, it's bad. If it's in the anterior leads, that's an anterior wall STEMI coming. If it's in the inferior leads, that's an inferior wall STEMI coming. So in summary, the DeWinter sign is a very important pre-STEMI sign that you must be aware of. And it is now in the cath lab activation criteria in the American College of Cardiology guidelines, but not in the rest of the guidelines across the world, unless I'm missing something. It is not in the pre-hospital bypass criteria in many areas in UK yet, but it has started to appear there. So I think those who are working pre-hospitally in Leeds and Sheffield area in UK, they included the DeWinter sign in the bypass criteria. So if there is a patient with chest pain and a DeWinter sign in the ECG, the pre-hospital team will spot it and will bypass the nearest ED and will go to the nearest PCI center. When it comes to the timing for serial ECGs, there is no specific timing, to be honest, in the guidelines. No one is going to tell you exactly what's the ideal time frame, but it's important to be aware that there are serious changes that can happen within seconds in an ECG, and you should be prepared for this.